Hi everyone, welcome to another episode on the USMLE review series. And today we're going to be looking at the gastrointestinal pathology of achalasia. So in this video, I'm going to discuss everything you need to know about achalasia for the USMLE exams. So if you find this video very helpful, you could support me by liking this video and subscribing to my channel for more videos like these. All right, so an introduction to achalasia, it's a rare esophageal motility disorder. So most clinicians won't encounter it, but it is widely tested on the USMLE exam. So you definitely have to know a lot about this pathology. So it is as a result of lower esophageal sphincter dysfunction, where it fails to relax and may be hypertensive, high pressure in some cases. So it's pretty much a very tight lower esophageal sphincter. And the esophagus would also lack peristalsis, so that would cause food not to get from the esophagus to the stomach. So as a result, the food would remain in the esophagus. And it is a functional obstruction at the gastroesophageal junction, um, difficulty swallowing, and food passage. So um, a chief presenting complaint would be dysphagia or difficulty swallowing. It is a functional obstruction and not a mechanical obstruction. That's an important point to know because a functional obstruction states that it's really as a result of lack of propulsion and peristalsis and contraction. A mechanical obstruction is more so an actual mass or some sort of structure preventing passage of materials. So, for example, if there was an esophageal cancer or growth, that would have been mechanical obstruction. If there was something like esophageal ring, that would be an example of mechanical obstruction. All right, so this is a diagram that depicts what it looks like, normal versus achalasia. So this is your normal esophagus and stomach, and in between it, you have your lower esophageal sphincter. What normally happens when food comes down into the esophagus, into the stomach, usually this lower esophageal sphincter would relax and dilate to allow the passage of food into the stomach. But what happens in achalasia? The lower esophageal sphincter don't relax, it remains in a very tight and contracted state. So as a result, food does not get from the esophagus into the stomach and it accumulates in the esophagus and it causes it to dilate here. All right, so the etiology, the cause of achalasia, and this is a really important point to know. It is as a result of degeneration of nerves in the myenteric plexus and degeneration of inhibitory neurons in the lower esophageal sphincter, where there is loss of neurotransmitters such as VIP and nitric oxide. And as we know, nitric oxide is a vasodilator. And what will happen in severe cases, you could lose cholinergic function also. Um, the etiology is unclear. Mostly possible causes would include an autoimmune response, viral infection, and genetic factors. And the most common cause in the US is primary idiopathic achalasia, where the cause is mostly unknown. But there are conditions that would cause secondary achalasia, known as pseudoachalasia, where it's one parasite would be the Trypanosoma cruzi, the cause of Chagas disease that could cause achalasia, degeneration of the neurons and cause achalasia. And in this case, it will be called pseudoachalasia. And also malignancies such as gastric cancers could also cause pseudoachalasia. So this is referred to as secondary achalasia. All right, so this is just a review of the histology of the GI tract, showing us where the myenteric plexus or Auerbach plexus really is. So let's start with a schematic diagram. These are the layers of your GI tract in general. We have our mucosa, which has the epithelium lining it, underlying lamina propria. And then we have our submucosal layer. Then we have our muscularis layer, which contains a smooth muscle, and then we have our serosal layer. So the myenteric plexus or the Auerbach plexus is in between the muscularis layer. So that's where it is. And the nerves that form the myenteric plexus, these neurons, it is these neurons which are degenerated in achalasia. And if we look at the hematoxylin and eosin section here on this slide, we would see two layers of smooth muscle, longitudinal and cross-sectional layer here. We see the Auerbach plexus or the Meissner's plexus in between these two smooth muscle layers. And it allows for contraction and relaxation of the smooth muscles. So it's important also to know that the neurons are degenerated in the myenteric plexus, but not the Meissner's plexus. The Meissner's plexus is the submucosal plexus. That one is not affected in achalasia. It is the myenteric plexus or the Auerbach's plexus, which is affected, located in the muscularis layer of the GI tract. All right, so the clinical presentation of achalasia, the onset is usually between 20 to 60 years old. It's insidious and gradually progressive. So some symptoms, the primary symptom that patients would present with is dysphagia or difficulty swallowing. And important feature to know about the dysphagia is that these patients will have difficulty swallowing both solids and liquids. So this is a very key feature in disorders that would cause functional dysphagia, um, meaning that this is dysphagia caused as a result of lack of peristalsis and motility of the esophagus in comparison to um, mechanical causes of dysphagia, like if a patient would have esophageal cancer or esophageal web, that would be a mechanical cause of dysphagia. And in that case, the patients would have difficulty swallowing solids alone. The solid food would get stuck and liquid would be able to pass. But in functional causes of dysphagia, these patients would have difficulty swallowing both solids and liquids. So that's why this is a key feature that could point towards achalasia. Another symptom would be regurgitation. So undigested food would come back up, especially at night when a patient is in the supine position. And this poses a significant risk for aspiration, and this could lead to recurrent pneumonias, and it could even lead to lung abscesses. So these patients would have these complications if this condition is not treated. Another less frequent cause would be chest pain and abdominal chest discomfort. Weight loss is also a feature because nothing is getting from the esophagus, or very little is getting from the esophagus into the stomach. And we should also, when a patient presents with weight loss, we should also consider malignancies in general. And in this case, we can consider pseudoachalasia if patients present with significant weight loss and dysphagia also. All right, so the diagnosis of achalasia is probably the most testable area on the USMLE exams. So how would we diagnose achalasia? The first study we could use is barium swallow. This is a test that's typically initially used because it's less invasive. It really involves a patient taking barium, and it's a type of contrast. They would swallow it, and fluoroscopy X-ray would be done to see where that barium goes. So this is an image shown here. So in a patient with achalasia, during that barium swallow, you might see lack of peristalsis during swallowing. Um, you're going to see esophageal dilation, potentially significant, and you can see that in this X-ray here. Um, the white area is actually the very dilated esophagus, you see, and then you're going to see a bored beak appearance in the distal part of the esophagus. So narrowing, and that's as a result of narrowing at the lower esophageal sphincter. And this is known as the bored beak appearance in patients with achalasia. All right, so esophageal manometry is the gold standard way in which we would diagnose achalasia. So I've included a bit about what esophageal manometry really is. So the purpose is to diagnose esophageal motility disorders, and it evaluates esophageal function. So it measures pressures in sphincters and coordination of propulsive movements in the esophagus, and abnormal contractions if they're present, and is used for diagnosing our condition achalasia, also useful in esophageal spasms, scleroderma, and sphincter issues. It's also used in evaluating hiatal hernia and esophageal function before specific treatments. All right, so like I said, esophageal manometry is a gold standard way in which we would diagnose achalasia. So this is a really helpful chart to demonstrate how esophageal manometry is able to diagnose achalasia. So we would see, if we pay attention to the notes here, incomplete lower esophageal relaxation. So the measured pressure stays high during swallowing. So I'll demonstrate that shortly. And there's failed peristalsis, no coordinated esophageal contraction, 100% failure of esophageal contraction. So if we direct our attention to the section on achalasia here and the section on which is normal here, and we look at the headings, we've seen the patient swallowing. We tell the patient to swallow, and we monitor the pressures in the pharynx, the upper esophageal sphincter, the esophagus, upper, middle, and lower, and the lower esophageal sphincter. So when we tell the patient to swallow, we see here that the esophageal contractions are a bit decreased. The pressures are a bit decreased than it should be if you compare it to normal. But then when you get to the lower esophageal sphincter, where our pathology lies, and you compare it to normal, you see normally the lower esophageal sphincter should relax. The pressure should have decreased to allow the lower esophageal sphincter to open and allow food from the esophagus to enter the stomach. But what happens in achalasia, this relaxation does not occur, and the pressures in the lower esophageal sphincter stays high. So as a result, the sphincter don't relax, and food remains in the esophagus. So that's if we see a tracing like this, we would be able to make the diagnosis of achalasia in that patient. There's also some very other important pathology shown here. So one example would be scleroderma. If we compare scleroderma to normal, you would see that when the patient swallows, you would have initially an increase in pressures as the esophagus contracts. But when you go to the middle and the lower esophagus, where the fibrosis as a result of scleroderma is more common, you would see that the pressures are lower, right, as a result of fibrous esophagus. So if we come to the lower esophageal sphincter, we see that in scleroderma, the pressures remain very low. So that means in scleroderma, there would be reflux of contents from the stomach into the esophagus. And this would cause the patient to have a lot of reflux of food and reflux of stomach acid into the esophagus, causing symptoms like heartburn, and it could increase the risk for transformation of the esophageal mucosa in that area, potentially leading to cancers. So another pathology here, which is also important for the USMLE, would be diffuse esophageal spasms. If you look at the manometry done on diffuse esophageal spasm. You see as a patient takes a swallow, you see that there's multiple spikes of contractions here. So in this diffuse esophageal spasms, you would have these multiple uncoordinated contractions occurring in the esophagus. And you see as you go down to the lower esophageal sphincter, the pressures would remain low. So these are some manometry characteristic of these various important disorders that you would have to know for the USMLE boards. All right, so in the differential diagnosis for achalasia, we would see here that there's diffuse esophageal spasms, which is also a functional cause of dysphagia. Scleroderma, which is also a functional cause of dysphagia because there's problems with contraction and peristalsis of the esophagus. And there's other causes of achalasia so that we could consider. And these are mostly mechanical causes of dysphagia. Gastroesophageal reflux disease, which could lead to strictures and so on. Strictures themselves, the Skarsky ring, hiatal hernia, and paraesophageal hernia. All right, so you do have to know a bit about treatment for achalasia. The two procedures commonly done are pneumatic balloon dilation and Heller's myotomy. So the more common procedure done is pneumatic balloon dilation. So just a bit about this procedure. You would have a catheter inserted via the oral cavity into the esophagus. It goes all the way down to the stomach. And associated with that catheter, you would have a balloon, and the balloon will be positioned at the level of the lower esophageal sphincter and it will be inflated. When it's inflated, it would create um, opening at the lower esophageal sphincter, and that would help to relieve the constriction that was present there. And the other procedure that um, is done is Heller's myotomy. This could be done via the open method or the laparoscopic method. And basically what it is you're gonna make an incision at the lower esophageal sphincter in an attempt to try to um, relieve the constriction at the lower esophageal sphincter. So in terms of the efficacy of these two procedures, the pneumatic balloon dilation is similar to laparoscopic Heller's myotomy at 5 years. And the main complication of these disorders are esophageal perforation. And another complication, as you may imagine, if you create a space between the esophagus and the stomach, that would result in um, reflux of gastric acid back into the esophagus. All right, so there are other options for treatment like the perioral endoscopic myotomy, and this is comparable to laparoscopic Heller's myotomy, and it is less invasive option because it's an endoscopic surgery and it's not an open or laparoscopic surgery, and we don't have to make an incision on the patient. So this type of surgery, we have good short and long-term outcomes, but you have a higher post-procedure gastroesophageal reflux disease as compared to the laparoscopic Heller myotomy. Another option that we have is botulinum toxin injection, sorry. And you should know a lot about botulism toxin, so ensure you review and know everything about how this toxin works. Remember, it decreases the release of acetylcholine at the presynaptic terminal, and it is a muscle relaxant. So this is used in in achalasia. It's injected into the lower esophageal sphincter, and it causes muscle relaxation, and it allows the sphincter to relax and accommodate the movement of food from the esophagus into the stomach. And it has shown some improvement initially, 7 to 80% improvement, but it declines over time, meaning that the more you use this botulism toxin injection, the less it works over time. And other options, you could use medications like nitrates and calcium channel blockers, which are dilators, but it hasn't proven very good and very effective, so it's generally not recommended. All right, so prognosis and complications, some poor prognostic indicators. We have esophageal dilation, tortuosity, late stage complication, pulmonary aspiration, watch for nocturnal regurgitation. So this is gonna be a significant issue in causing recurrent pneumonias for these patients. It is difficult to manage pulmonary complications from aspiration and esophageal cancer. So latest evidence that comes out shows that it's not currently thought to be increased, although previously it was thought to increase esophageal cancer risk, but it's not. All right, so that's all you need to know about achalasia for the USMLE exams. So thank you for watching this video. If you liked this video and found it very helpful, please leave a thumbs up and subscribe to my channel for more video like these. See you in the next video. Bye.